Okay, so welcome everybody. We are thrilled to have you here for the February JVS Online Journal Club. Each month we pick 2 articles from the current JVS. This month we have predictors of outcome in diabetic patients undergoing infra-popliteal endovascular revascularization for chronic limb-threatening ischemia. And Dr. Yap is here with us to discuss or to answer questions about her paper. And then of course, intraoperative blood pressure lability carries a higher risk of headache after carotid endarterectomy. And Dr. Daniel Lee, Dr. Philip Batista, and Dr. Joseph Lombardi are here from this author group. Our 2 host institutions this month are Penn State, and we're thrilled to have Dr. Tanya Floor, who is an assistant professor of surgery, and also Dr. Besma Neem, who is one of their 4th year integrated residents. From NYU, Dr. Karan Rockman and Dr. Chong Lee. Dr. Rockman is a professor of surgery, and she's the program director for vascular surgery, and Dr. Lee is one of their 4th year residents. As I mentioned, we have some of the authors. Trixie Yap is a 2nd year resident who's at St. Thomas Hospital. And I didn't know that Dr. Lombardi was going to make it. I did have your slide up here earlier, but again, we got the vacations mixed up. And then Dr. Lee was kind enough to join us as well. He's on paternity leave. His wife just had a baby, but he was able to join us between duty to answer some questions. And of course, Dr. Philip Batista, who's an assistant professor at Cooper. Our special guests who will be discussing the articles and moderating the discussion as well are Dr. Joseph Mills, who's professor and chief of vascular and endovascular surgery at Baylor College of Medicine, and Dr. Louis Schwartz, who is a clinical professor of surgery at the University of Illinois. Just some housekeeping. We ask that you do stay muted. We will solicit questions in the chat, and our discussion leaders and moderators will bring those questions up and go through them. We do record this event, so it's on demand access later on if you need to review it or if there's things you want to look at. And of course, our March JVS Online Journal Club will be coming up on March 15th at 8 p.m. Eastern. It's being hosted by UCSF and by Carolinas Medical University. And we're finalizing the dates for April through August, and those will be posted on the SBS website, and you'll see more come out. So with that, I will stop sharing my screen and we will turn it over to our first faculty to introduce the first article. Thank you.
Okay, I just want to make sure that everybody can see my screen. Is that correct?
That looks great. If you want to put it in the presenter mode, we can swap
Great.
the screens.
So I was excited to see
Tanya,
this.
you're on 2 screens. Just
Okay.
go ahead and swap, do display settings up at the left. Yep. And then swap them.
Is that
Perfect.
All right?
There you go.
Thanks, Misty. I was really excited to see this paper as an option. A big part of the patient population that I've been treating, obviously, and probably you guys as well, is diabetic. And it's probably one of the most frustrating populations that we treat. And definitely with our techniques and endovascular interventions becoming more adept and patients living longer and having more comorbidities and still needing some intervention for revascularization, I thought it was appropriate and timely. Boy, when you sit down and you try to do a review of all the research that's been done in this area, it's pretty overwhelming. When I typed in diabetes and peripheral arterial disease, I got over 11,000 research articles. And obviously, we're not going to go through all of those in a few minutes here before we introduce the paper, but it's hard to kind of organize when you stop and you try to make sense of everything that's already known. And I set it up with this Venn diagram because I thought, obviously, we're interested in peripheral arterial disease, but there's a lot of research that's very pertinent in the coronary world. And I'm not going to go through a lot of that other than to say that some of the expected Preoperative factors, including hemoglobin A1c and hyperglycemia or blood glucose prior to any intervention, are very predictive for bad outcomes after these interventions. So moving forward, how is our diabetic vascular disease really different from our non-diabetic vascular disease? This starts with a little history lesson. Back in 1964, a true surgeon scientist, vascular surgeon, Dr. Strandness, proposed this paper. He described a number of lower extremity arterial systems after isolation from amputation specimens, and noted probably for the first time the difference between diabetic vascular disease and how in non-diabetics there was more an incidence of atherosclerotic disease in the aortoiliac system as opposed to the lower extremity arterial system. And confirming this, this group showed nicely using the Bollinger scoring system of atherosclerotic disease, the same difference between diabetics and non-diabetics, really showing those differences in the profunda, popliteal, and tibial vessels as being the areas where diabetics suffer the most. We also know that diabetic vascular disease has that microvascular component. So at a pathologic level, there is an increase in the amount of basement membranes surrounding the vasculature. And on top of it, there's a decrease in the amount of capillaries at the level of the soft tissue. And this sets that patient up for lower incidence of getting nutrients and oxygen delivered to areas of repeated trauma. So that plus an existing microvascular component, similar to what we would expect with our normal atherosclerotic disease, sets the diabetic patient up for more issues. So in general, how does diabetes affect our vascular surgery outcomes? Well, we all kind of know, but we don't know. When you start looking through the literature and try to find specifics, it's not easy to find. Here I found one group that proposed that diabetic patients have a higher amputation rate and lower limb salvage rate as compared to non-diabetics when undergoing endovascular interventions. And not everybody agrees with this, and I'll show you that. This is a pretty large group out of Japan. It's a retrospective study that divided the patient population into two patient populations, diabetics and non-diabetics, and looked for amputation rate as well as limb salvage. Interestingly, the mortality difference pretty far out was not seen, but major amputation rate was higher for the diabetic patient population, and I'm showing the Kaplan-Meier curve for limb salvage rates. Interestingly, with this study, they showed that independent predictors of major amputations for diabetics were different than that of the regular atherosclerotic patient. They were and included the hemoglobin A1c, a pre-existing infection, poor ADLs, younger age, and a procedure that failed. Independent predictors for major amputation for patients with just garden variety atherosclerotic disease was procedure failure only. So those other groups that don't necessarily agree that you can't get good limb salvage rates with interventions, they do show that limb salvage can be equivalent to patients without diabetic vascular disease, but they admit that patients with diabetic vascular disease require quite a bit of close follow-up. And that patient population is probably going to need more interventions on your behalf. So you can't let those patients go. Is an elevated blood glucose associated with a poor vascular surgery outcome? I think it's safe to say yes, but not everybody can consistently show it. So perioperative glycemic control as assessed by this group within 6 hours of surgery through the 48-hour postoperative period was shown to be associated with an increased rate of death, major amputation, and graft occlusion for an elevated perioperative blood glucose. This group also showed that it was an independent predictor for wound complications as well. So in a nutshell, lower extremity bypasses, patients with an elevated blood glucose going into surgery, their outcomes aren't as good. Might want to think about that blood glucose before going into surgery. Well, what about poor glycemic control prior to endo interventions? That's one thing that we're going to talk about with our paper, but there's another paper out there that shows that poor glycemic control is associated with lower primary patency rates. This was a nice study that also looked at infra-popliteal endovascular interventions with patients that were mostly Rutherford stage 5 and 6. They showed that if your blood glucose was elevated in the preoperative period above 144 milligrams per deciliter, your primary patency rate, primary assisted patency rate, and secondary patency rates were all lower as compared to those with a lower or normal blood glucose. And your major adverse limb events were also increased for that patient population. But interestingly, and this seems to be the general problem, is we can't all show a consensus for everything with every patient population. So this group was not able to show that hemoglobin A1c, a preoperative hemoglobin A1c greater than 7, was associated with a lower primary patency. So have other groups been able to show that? Have other groups been able to show that a hemoglobin A1c is associated with a poor vascular surgery outcome? Yes, definitely. This is a pretty large VA-centered study looking at over 26,000 VA patients that underwent revascularization. So all types of revascularization, including endo and open, and assessed whether or not these patients' mortality was different as compared to patients with a normal hemoglobin A1c, and whether or not these patients were at risk for increased amputation or major adverse limb events. This study definitely showed, and you can see the Kaplan-Meier here, that there was a difference. If you divide the patient population by hemoglobin A1c going into surgery, those patients with the hemoglobin A1c greater than 7 were found to have a higher rate of major amputation and major adverse limb events as compared to those with a lower hemoglobin A1c. And what was nice is that they showed a dose-dependent relationship. So as the hemoglobin A1c increased, those rates of bad events increased as well. And then lastly, another nice study out of Japan looking at diabetic patients with hemoglobin A1c that was found to be elevated undergoing endovascular interventions for critical limb ischemia. This group also showed a dose-dependent response with regards to elevated hemoglobin A1c, and that's depicted in the figure on the left, figure A. They divided hemoglobin A1c by quartile, going from 6 to 6.1 to 7 to 7.1 to 8. And they showed that increased event of amputation rate. On the right, they also had two other independent predictors of an increased rate of major amputation, being infection and the need for hemodialysis. So you put that together with hemoglobin A1c that's elevated preoperatively, and you've got a patient that's set up for potential disaster, maybe no matter what you do. So in summary, diabetic vascular disease preferentially treats different vessels. We know that, but our vascular surgeons have showed it, and it's nice to review. Diabetics have decreased primary patency after endovascular interventions and may have a higher rate of amputation and decreased rates of limb salvage if not followed closely. Perioperative blood glucose is associated with poor outcomes after lower extremity bypass and decreased primary patency after endovascular interventions. And an elevated hemoglobin A1c is associated with higher amputation rates after different methods of revascularization. And now I'll turn it over to our vascular surgery resident, Dr. Besma Najim, to discuss our paper.
Okay. All right. Good evening. My name is Besma Najim. I'm a PGY4 vascular surgery resident at Hershey Penn State Medical Center. I'd like to thank the organizers for the opportunity to present this paper. I'm going to talk about predictors of outcome diabetic patients undergoing infra-popliteal endovascular revascularization for chronic limb-threatening ischemia. This paper was done by Dr. Yap et al. From Guy's and St. Thomas NHS Foundation, United Kingdom. So as Dr. Floor was talking about, diabetes is a well-known risk factor for peripheral arterial disease, and diabetic patients are at increased risk for amputation and mortality compared to non-diabetic PAD patients. They often present later with a chronic limb-threatening ischemia, likely due to the effect of peripheral neuropathy and associated infection. Moreover, PAD in diabetic patients characteristically involve infra-popliteal arteries. Systematic reviews and meta-analysis of randomized trial have shown infra-popliteal endovascular revascularization in patients with CLTI to be feasible and relatively safe. Therefore, the objective of this study was to identify the impact of poor perioperative glucose control on long-term outcomes after IPEV, and further to identify any other factors that can independently be associated with poor outcomes. This was a retrospective review of prospectively maintained data. Patients were included consecutive diabetic patients undergoing IPEV with CLTI stage 4 through 6. Patients were excluded if they have a prior same limb intervention undergoing hybrid revascularization, and if they have less than 6 months of clinical or radiologic follow-up. Additionally, patients with less than 24-hour pre-op CBG measurements were also excluded because they don't have enough data. Of note, patients with inflow disease treated endovascularly were not excluded. Patients' demographic and procedural details were collected. Perioperative CBG values and HbA1c levels were collected from the EMR. CMG measurements were gathered from 6 a.m. on the day of the procedure to the day of discharge, and or up to 6 days post-operatively. Similarly, HbA1c results within 3 months before the index procedure and within 3 months after discharge were collected. Primary outcomes of the study were binary, more than 50% pre-stenosis, primary assisted, and secondary patency. Secondary outcomes were amputation-free survival and freedom from major adverse limb events. This was defined as a composite of major amputation of the revascularized limb and or needs for re-intervention on the target vessel. In a total of 249 patients were included. 46 were ultimately excluded due to lack of follow-up or lack of glucose measurements, leaving 203 patients with 213 limbs. A total of 437 target vessels were treated, and the distribution of the vessels involved are shown in this slide, just more or less homogeneous. Modality of treatments, the majority of patients underwent plain balloon angioplasty, 50%. Drug-coated balloons were 15%. Drug-eluting stents, interestingly, were utilized in 30% and bare metal stents in 5%. Of note, the authors did mention that stenting was used as mostly as a bailout option. But the majority of the patients in the preferred intervention was plain balloon angioplasty. So looking into patients' demographic from this table, you can see that it is all as expected. Mean age 70, majority are male. Expected distribution of comorbidities, type 2 diabetes more than type 1. But what I found interesting to me is that only 22% of this cohort were smokers, which is like highlight excellent smoking cessation program in the author's institution. Also, only 13% of the patients were rest pain, but the rest were, the majority were having some degree of tissue loss. Technical success per target vessel was 87.2%. This was defined as immediate patency with residual stenosis of less than 30%, and this was judged by an independent operator. However, all patients had a minimum of a single vessel in line of flow to the foot on this study. Interestingly, isolated tibial revascularization was only 42%, but 58% required tibial plus proximal revascularization, either the SFA or popliteal lesions. At 1 and 2 years, respectively, you can see that the primary stenosis was 35 and 52%, primary patency 61 and 50, secondary patency 71 and 59%. So I think it's also similar to prior reports on term of patency for tibial interventions. 30-day mortality was 3%, and at 1 and 2 years, overall survival was 82 and 73% respectively. Amputation-free survival and F-male was approximately 62% at 2 years. Now, moving on to the impact of the glycemic control, which is the aim of this study. You can tell that the pre-op HbA1c did not significantly affect the risk of stenosis. However, post-op HbA1c that was higher than 6.5% was associated with higher risk of stenosis, restenosis, at 56% compared to 44% in patients with HbA1c less than 6.5 at 2 years of follow-up. This figure shows that the risk of restenosis per mean perioperative CBG level, more than 7 millimole per liter, which corresponds to 126 mg per dl. And you can see that the risk of restenosis at 2 years is significantly higher, at a rate of nearly like 55% compared to 35% in patients with less than 126 mg per dl. And this was statistically significant. This is an unadjusted analysis. Interestingly, neither pre-op nor post-op HbA1c affected amputation-free survival. F-male was worse in patients with high post-op HbA1c. So at 2 years, the freedom from male was only 58% compared to 79% in patients with low HbA1c. Again, this was also statistically significant. Neither pre-op HbA1c nor mean CBG affected F-male. Another interesting finding is that post-op DAPT was associated with better amputation-free survival in this study. And finally, we're talking about the adjusted analysis. The authors did perform Cox regression analysis to look into long-term outcomes. In this analysis, looking at binary restenosis risk, the post-operative single agent antiplatelet was associated with higher risk of restenosis compared to dual, as well as high CBG. However, post-op HbA1c, which was significant in the univariate analysis, lost its statistical significance. Amputation-free survival was worse for patients with renal failure, but it was better for older patients and patients with who were discharged on post-op DAPT. Again, this is also confirmed by a prior study that younger patients have worse risk after intervention. FMAL was better in patients with rest pain compared to patients with tissue loss and in patients on DAPT. High post-op HbA1c was associated with worse FMAL in the adjusted analysis. In conclusion, poor perioperative glycemic control denoted by CBG levels was associated with increased restenosis rates. Higher post-operative HbA1c levels were also associated with worse freedom from major adverse limb events. Post-operative DAPT was independently associated with both improved amputation-free survival and FMAL. This study has some limitations, included that while it's a comprehensive analysis, it is a retrospective analysis of data from a single center. Therefore, generalizability may be of a question. We saw that the patient population, only 22% are smoker, and that's not the experience of a lot of other institutions. There's also a risk of selection bias. HbA1c values were collected within a variable time frame during the pre and post-operative period. And as we know, it's a cumulative measure, so it's difficult to ascertain the effect of pre and post values considering there must be an overlap. No data collected on glycemic control during the long-term follow-up after the intervention. There's also potential confounders and modifying factors besides glycemic control that could account for worse outcomes. And lastly, 58% of patients underwent above-knee intervention. However, this was not really accounted for in the adjusted analysis, but that could have impact significantly the outcomes. Again, thank you for the opportunity to present, and I'm happy to take any questions.
Well, thank you, Besma. We'll let you stop sharing your screen and we'll have our moderator just make a few comments and then take over the questions, okay?
Okay, so this is a really interesting paper, and I think the discussion might even be more interesting than the paper itself. But the reason I think it's important is that there's been too much of a focus in the vascular world on treating lesions. And I heard a lecture from Nicholas Scopper a few years ago at the International Working Group on the Diabetic Foot, and said we spend all this time trying to treat lesions and save limbs, but if you look at the therapies that actually make patients live longer, like dual antiplatelet therapy, like statins, we'll talk about that, and medical management control of glucose, we don't spend much time on that, and the mortality on these patients is still really high. So I think I compliment the authors for looking at something besides the lesion itself. There are some issues with the paper. So the conclusions, basically they ended up with 249 patients and 46 were excluded because they didn't have adequate blood glucose levels or were lost to follow-up. And they treated 437 different lesions. The mean follow-up's about 1.5 years. So the main findings were that post-operative capillary glucose levels were an independent predictor of binary restenosis, that post-operative DAPT was an independent predictor of amputation-free survival and freedom from Mayo. And if you had better baseline renal function, you had better amputation-free survival. So the latter finding about GFR is pretty well known. DAPT, most people would agree with, but the post-operative glucose levels is kind of interesting. So I had a couple questions for the authors, and which I'll tie in with ones I see in the chat. So I'll go out of order. Let's talk. There's a couple questions about hemoglobin A1c. And so my questions were, is better glucose control post-operatively correlated with a lower risk of restenosis, but was it associated with either more rapid wound healing or improved amputation-free survival? I think in your paper, it didn't show any effect on amputation-free survival. And then do you have serial hemoglobin A1c measurements over time? So if you don't have good perioperative control and you subsequently make it better, does that improve outcomes? And there was a question in the chat about what happens to these patients. How long does it take to improve an A1c? And if you were to do that, could that improve your outcomes? So those are kind of related questions to the, I think your measurements were mostly perioperatively, is that correct?
Hi, everyone. First of all, thank you for the opportunity to discuss my paper. Yep, those are really good questions. So that's correct. The HbA1cs were mainly perioperative. We didn't really have consistent HbA1c data further than 3 months post-discharge. So majority of it was either 3 months pre-op or 3 months post-op. And I agree, it would definitely be useful to assess long-term HbA1c outcomes and then follow their glucose control and correlate that to patency rates and wound healing. But we didn't have the data on that, unfortunately. In terms of the question about,
over what time period, if you tried
healing.
to correct the A1c, over what time frame, how long does that take? So the A1c reflects a longer time period, right, than just a spot glucose measurement.
Yeah, so I mean, from my understanding, it takes at least a couple months for the HbA1c to correct. We didn't actively try and correct the HbA1cs in these patients in the outpatient setting. It was just mainly focusing as an inpatient to have sort of normal capillary blood glucose targets rather than tight intensive controls. In our trust, we have diabetes advisory team, which involves diabetes clinical nurse specialists, as well as the diabetic medical consultants who review these patients in the perioperative period and advise on blood glucose targets. In our trust, the protocol is to have it sort of standard targets rather than intensive targets because of the risk of hypoglycemia and those associated risks.
Yeah, and then a related question, is it possible that glycemic control is a surrogate marker? So it may be that patients in whom their sugar is easier to control or better controlled also take statins, also take their blood pressure medicines, and perhaps it's just a marker for overall compliance rather than specifically the glucose level. What do you think about that?
Yeah, absolutely. That's a good observation. It should certainly be the case. I think it was quite difficult to answer this question, and to do this, we did a multivariable analysis to try and tease out any other independent relationships. And of all the factors we analyzed, which did include statin use, we didn't find any others that were significant other than the ones that we mentioned. We can say definitely that by comparing the preoperative HbA1c groups, the less than 6.5% and more than 6.5%, we didn't find any difference in the disease severity parameters and also no difference in the technical success rate. But based on all the data that we had, these were the sort of confirmed conclusions that we could draw.
Yeah, there's another chat question about statins. So there's some evidence that statins reduce amputation risk in broad groups of PAD patients and maybe CLTI patients. And whether low or high dose statin matters is kind of unclear, but did you guys look at statins?
So yes, we did, but in our trust, the unit protocol is for all patients to be on best medical therapy, which would include high dose statins. So it would be exceedingly rare for patients to not be on any statin at all. Or if they were on a low dose statin, it would be due to some sort of clinical reason. So majority of our patients would already be on that treatment. Therefore, we didn't find it to be significant, or we wouldn't be able to compare it because all of them would have been on the same
So in your
medication.
trust, are you able to track things like that? Whether patients are on statins and you have to check a box if they're contraindicated or they're not on them for some other reason? How does that work?
Yeah, so we have an online prescribing system at our trust. We're actually doing an audit at the moment to assess whether all our patients are on best medical therapy at the point of discharge. Sorry, my cat is just trying to get involved in this call. So yeah, so we're able to follow, we'll be able to assess whether these patients are on the correct medication. Certainly we are auditing this in all our inpatients.
And then another question, if you look at, so it looks like you had a cutoff value for glucose control, but if you think about it as a continuous variable, is it possible to analyze the data that way? Is there a relationship between various levels of A1C or glucose control perioperatively?
I think we sort of did it as a cutoff because it was the easiest way to compare the two, whether it was good blood glucose control or not. But certainly, I think there would be merit in looking at it as a linear variable. Okay.
Now, the stickier question. So you used Rutherford, you didn't use Wi-Fi, and Wi-Fi has demonstrated over the last 7 or 8 years it's a really strong predictor of amputation risk, especially stages 3 and 4, which are different than Rutherford 4, 5, and 6. So that as far as I'm aware, the 2 highest predictors of amputation risk are Wi-Fi clinical stage 4 and renal failure. So why did you use Rutherford? And then did you use Rutherford hemodynamic criteria, or did you just use the classification of the wound that appears in Rutherford? So the problem with Rutherford is most of the wounds we treat are 5s, right? 4s are rest pain. 5s mean you have a salvageable foot at a TMA level or less. And 6 actually means you have to do a Chopard, a Liz Frank, or some complex heel reconstruction, right? So how did you define Rutherford, and why did you choose to use that rather than Wi-Fi?
So the Rutherford classification we used was just the clinical grading, be it rest pain, tissue loss, or rest pain and tissue loss. At the time of the data collection, Wi-Fi wasn't routinely used, and we didn't have enough data to retrospectively calculate the Wi-Fi scores to include it in the analysis.
Okay.
I think that
And
we've had
one
a
other
great
lesion
discussion.
question. I'm sorry. Can I do one more lesion question?
One more,
I promise. So one of the concepts that gets away from TASC is this new TAP, target artery path concept that comes out in the global CLTI guidelines. So that is limb-based, right? If you treat multiple lesions, then it means your entire TAP is patent. So how did you assess patency when you treated SFA popliteal disease in over half your patients? And then in some of your patients, you treated more than one tibial. So when you're referring to patency, is that patency by lesion, or is that patency by the entire treatment session that you undertook? Does that make sense?
Yeah. So the patency was calculated per tibial vessel treated, rather than as an overall patency. We use GLASS routinely now, but not at the time of collecting data. That's why we
yes, I think that's going to be really useful if we use GLASS going forward, because you can make the argument you might treat the SFA, the POP, and a tibial, and we all know the tibial restenosis rate is pretty high, but you get things open long enough to heal the foot, then your tibial restenosis, but the SFA and POP are still open, and you have a good outcome. So I think GLASS and TAP will help us get at that.
Absolutely have to come back to this the next time that Dr. Yap presents. So thank you, Dr. Mills. You always generate such great discussion for us, but we have one more paper, and we will probably go a little bit over the hour if people want to stay. Dr. Rockman, would you like to start us off?
Or how's that? Am I good?
Perfect.
Okay, so we're going to talk, the title of the paper that I'm supposed to introduce the topic today is Intraoperative Blood Pressure Lability Carries a Higher Risk of Headache After Carotid Endarterectomy. And we're talking about headache after carotid endarterectomy. We're really using this as a surrogate for cerebral hyperperfusion, which is the subject I'd like to introduce today. So this is clearly a clinical syndrome following carotid revascularization. We're going to talk about endarterectomy today, but this does and can happen after stenting procedures as well. It's clinically characterized by severe ipsilateral headache, seizures, and in its worst forms, intracranial hemorrhage, which is often fatal. The pathophysiology, there's felt to be a lack of ability of chronically ischemic intracranial vasculature to constrict or to be able to auto-regulate following the restoration of normal perfusion to an ischemic area. We think that this is much more common in patients with severe occlusive disease bilaterally or contralateral occlusion, particularly in the setting of a recent stroke. And this syndrome is really the reason why we hear this old-fashioned advice, very old-fashioned advice these days, that patients who have had a large stroke, you don't want to operate on them early, right? Because you don't want to get hemorrhagic transformation of that ischemic penumbra. Important to note that the presentation is usually later than that of the much more common postoperative thromboembolic strokes. Those usually happen within 6 hours of surgery, whereas cerebral hemorrhage can happen 2 to 3 days later. And this is really why a CAT scan is mandatory in patients with severe headaches following carotid surgery. It is rare overall, but remember, carotid endarterectomy is always a prophylactic operation. So we really need to reduce all complications, particularly ones that can be fatal. The background material and data I'm going to give you is really almost solely from what I think is an excellent paper by Dr. Grace Wang. Now, I happen to be a co-author on this paper, but she really deserves all the credit for, I think, using the VQI in a very, very nice way to look at a very rare but important complication. So this paper noted that there were significant patient-related risk factors that predisposed towards cerebral hyperperfusion. Ipsilateral TIA or cortical or ocular stroke were important factors, as well as contralateral high-grade stenosis or occlusion, as I previously mentioned. And they did this nice relative association of the preoperative patient-related variables to cerebral hyperperfusion syndrome. And you can see here, as I mentioned previously, a major stroke within 1 month of the procedure, as well as contralateral high-grade occlusion were both very strong predictive factors. And then the paper looked at operative variables, and there were other significant operative variables which were found to predispose towards cerebral hyperperfusion. The performance of an emergent or urgent case, which is typically in the setting of something like a stroke in evolution or crescendo TIAs, the need for re-exploration. And here we have for the first time postoperative hypertension, or interestingly, hypotension. So blood pressure lability in the postoperative period predisposing towards cerebral hyperperfusion. And then here you can see the entire multivariable logistic regression for the association between cerebral hyperperfusion syndrome and the preoperative, operative, and postoperative variables. And this pie chart showing the relative association of all these variables. And when you combine all these factors, you find that the most important predictive factor is in fact postoperative hypertension. And that is related to what we're going to talk about today. You know, at our institution, some of the surgeons, when they feel they have a patient who really might be at risk for this, a woman, a recent large stroke, very high-grade stenoses bilaterally, they will actually put the patient in the ICU for 24 to 72 hours after surgery with really, really strict hemodynamic monitoring. So it's important to recognize the patients who are at risk. So in summary, cerebral hyperperfusion syndrome is rare, but when it happens, it's devastating and it's often fatal. A recent major stroke in a patient who's undergoing carotid revascularization is associated with a 5-fold increase in the odds of cerebral hyperperfusion syndrome, and post-operative hypertension is associated with a more than 4-fold increase. So again, most clinicians in patients who are felt to be at risk will institute extremely strict blood pressure management in the postoperative period with close hemodynamic monitoring, but the role of intraoperative blood pressure changes is really unclear, and that's what today's paper is about. And with that, I will turn it over to Dr. Chong Li, who's going to present the paper itself.
Ron, do you want to stop sharing your screen?
Yeah, sorry.
Thank you.
There we go.
Perfect. Dr. Lee?
Yes, good evening. Can everyone hear me and see my slides?
We can.
Awesome. Thank you, Dr. Rockman, for the kind and thorough introduction, and I thank the JVS for allowing me to participate in the February Online Journal Club. My name is Chong, a fourth-year integrated vascular surgery resident here at NYU. I'll be presenting the paper titled Intraop Blood Pressure Lability Carries a Higher Risk of Headache After Carotid Endarterectomy, authored by Dr. Daniel Lee and Dr. Joseph Lombardi from the Cooper Vascular Surgery Division. As mentioned before, cerebral hyperperfusion syndrome is a devastating complication following CEA, and its symptoms ranges from headache to intracranial hemorrhage. However, its risk factors have not yet reached consensus in literature. These authors set out to examine the intraoperative and postoperative blood pressure variations as potential risk factor for post-op headache. This is a single center retrospective review at a tertiary care center from January 2010 to November 2019. It included all patients undergoing CEA for symptomatic or asymptomatic disease. It excluded those with incomplete charts. The primary endpoints were new onset unilateral headache or post-op intracranial hemorrhage. All data were reviewed manually by 3 investigators. Analyses were performed between those with and without post-op headache. Table 1 showed that out of the 4 surgeons, there were minor differences in intra and post-op blood pressure management, but they were overall similar and they followed the same recovery protocol. General anesthesia was used in all cases. 2 surgeons used somatosensory evoked potentials and eversion endarterectomy, and the other 2 surgeons were routine shunters and performed patch angioplasty. They identified a total of 735 patients. 430 or 59% underwent eversion, and 305 or 42% had patch angioplasty. The incidence of headache was 19%. 11 patients or 1.5% had no relief with analgesics or BP control, and CT showed that 1 patient or 0.1% had ipsilateral intracranial hemorrhage. Table 2 showed the baseline demographics between those with and without post-op headache. Gender, prior smoking, severity of carotid stenosis, and length of stay were statistically different between the 2 groups. A supplementary table showed that the distribution of antihypertensives were not statistically different between the 2 groups. Table 3 showed that the degree of carotid stenosis and their associated odds ratio for post-op headache. Stenosis of 70 to 89% was associated with a lower odds ratio of post-op headache, whereas severe stenosis of 90 to 99% was associated with a higher odds ratio. Of note, headache was not associated with contralateral stenosis of greater than 50% or method of endarterectomy. Table 4 shows the intra-op BP variables and their odds ratio with post-op headache. The authors found 4 variables: MAP peak, MAP variability, systolic blood pressure peak, and systolic blood pressure variability to have significant higher odds ratio for post-op headache. Out of these, the MAP peak had the highest odds ratio. Figure 1 is a graphic representation of the aforementioned intra-op blood pressure variables as predictor of post-op headache using the receiver operating characteristics and Udens J statistic. Of note, the inflection points are the blood pressure at which doubling of the odds ratio occurred. Figure 2 showed that there was no association of post-op blood pressure parameters such as post-op MAP variability with headache, as opposed to intra-op MAP variability. For discussion, the authors stated that intra-op blood pressure derangements, namely the peak MAP, demonstrate a significant association with post-op headache with a 1.4% increase in the probability of headache per millimeter mercury increase in the MAP. This finding is not isolated, as other intra-op blood pressure variables such as MAP variability, systolic peak, and variabilities were also associated with headache. Post-op hypertension, on the other hand, was not associated with headache and might not be a major contributor to cerebral hyperperfusion syndrome. The authors proposed that a state of chronic hypoperfusion with compensatory dilatation of arterioles is more sensitive to the changes in blood flow during the intraoperative period. This is supported by the finding that severe degree of stenosis, 90 to 99%, is associated significantly with post-op headache. This study is limited by its retrospective and single-center design, having slightly different intra-op and post-op blood pressure goals among the 4 surgeons, and having only general anesthesia. The authors concluded that greater intraoperative variability in blood pressure are significantly associated with higher risk of headache. Thus, adhering to stricter intraoperative blood pressure parameters and limiting blood pressure variability might be beneficial at decreasing the incidence of cerebral hyperperfusion syndrome and its complications. This is the graphical representation for this paper made by the JVS. Thank you for your attention and the opportunity to present this paper.
I'm hoping this will generate just as much discussion as the last one. Dr. Schwartz, do you want to take it away? Lou, I think you might still be on mute.
So I am. It's a pleasure to be with you this morning. My name is Lou Schwartz. I'm a vascular surgeon in Chicago. We don't have too much time for questions due to the chronic verbosity of Dr. Mills, but this paper is extremely important. You know, if you do a lot of carotid endarterectomy, you're definitely going to see this syndrome. It's quite scary for the patients, quite scary for the surgeon. And I have a number of questions, and please chime in on the chat, and we'll get to as many as we can. First of all, the question on everyone's mind is what blood pressure parameters should I use intraoperatively for carotid endarterectomy? In my own practice, I tend to leave much of that management to the anesthesiologist. I really want to get into it with them. But one thing I do as a matter of routine is once the reconstruction is done, I ask the anesthesiologist to elevate the patient's blood pressure to test the suture line, because it's better to see bleeding intraoperatively when you can fix it as opposed to in the recovery room. So let me first ask our learned presenter and also the co-authors, tell me about, it's a very convincing paper. We're all convinced this isn't very easy to demonstrate. It's a very important finding, but tell us how to use it. Tell us what intraoperative blood pressure parameters you use for carotid endarterectomy, and when you don't get the parameters you want, how you correct them.
Well, Dr. Schwartz, thank you for that question. My name's Dan Lee. I'm one of the PGY4s over at Cooper. Thank you, Dr. DeMuzio, Dr. Humphreys, for the opportunity and hosting this journal club. So, Dr. Schwartz, to your point, you know, we try to work very closely with our anesthesiologists because they really are kind of driving the ship, so to speak, in terms of making sure that our patients don't become too hypertensive or hypotensive. Oftentimes what we see is when they're being induced, we'll see spikes in their blood pressures where they're hypertensive into like the 200s. And we really do try to communicate with our anesthesia colleagues that, you know, that's a little certainly too high. As we stated in the paper, we do tend to have blood pressure goals and a very familiar anesthesia team to be able to go ahead and anticipate that lability. So we typically ask that our blood pressures during, so prior to internal carotid artery clamping, we try to ask that the mean arterial pressure remains greater than 90 millimeters of mercury. And then once we are finished with the endarterectomy, we do kind of liberalize that to more of a normotensive range of 60 to 80. Now, clearly, there is issues in terms of, as demonstrated by this paper, where, you know, they're trying to meet that goal and they use levo often to try and augment the patient's pressures to get there. But we do certainly have a lot of communication with our anesthesia colleagues to make sure that we get that mean arterial pressure of just hovering at around 90 millimeters of mercury.
Well, thanks for that. There's some questions from the panel, but I have a few more if you don't mind. You know, do you, in your study, how many patients in the series actually had a mean arterial pressure greater than 125 in the operation, or a peak systolic pressure of greater than 214? Those are pheochromocytoma type pressures.
Yes.
You know, how many times did you observe that? I have to say, we're a room full of surgeons. We'd all agree that's not very good anesthesia.
No, I certainly agree with you. It is something that I was actually quite surprised. And so I had triple checked with the other reviewers just to make sure that we were actually all looking at, you know, true blood pressure recordings as opposed to like a transient peak that happened maybe because of like the positioning of the A-line monitor or something like that. And so for us, we had 157 patients who really did have systolic blood pressures that were greater than 214, 157, and that was sustained for at least about 5 minutes in terms of our recordings of it. And similarly, for mean arterial pressure, we had about 300 patients that seemed to have a sustained level that was that high. Surprising, absolutely, but certainly it was something that we noted and we were kind of concerned about. So that's kind of why we wanted to present this paper.
Now, the other finding in the paper that I found fascinating was your 19% rate of postoperative headache. I have to tell you, I don't remember the last time I had a patient complaining of headache, and I see this I see this comment in the panel from Enrico. He says that headaches can occur in up to 68% of carotid endarterectomy patients, but that's only if you have Enrico as a surgeon. But how is it that you have a 19% rate? Surely not all of these headaches are from hyperperfusion.
Oh, absolutely. Dr. Schwartz, I want to be very clear that headache we're using as kind of a early sign or a marker of something that we want to be extremely careful with. And so my team, especially when we're on the inpatient service, we are all trained to routinely ask our patients, hey, do you have a headache? We don't just leave it up to like, how are you doing? How are you feeling? Or a vague question like that. And following that question of, hey, do you have a headache? We always ask, where is the headache? Where is it localizing? Is it kind of radiating from the neck? And so we're very specific in terms of how we define what this headache is. Certainly 19%, it certainly seems like a large number. And most of our patients actually don't have any sequela from that headache. And so I think the real take-home point to all of this is that, yes, a headache could be one of those big warning signs. But what we want to do is make sure that if we go and mitigate the number of people who have headache as a symptom, might we not be able to better detect who is truly at risk for cerebral hyperperfusion syndrome by kind of lowering the risk of having patients who report headaches.
So the proposed pathophysiology always, frankly, has been a little bit confusing to me. Relative hypoperfusion and then restoring the blood flow. What's always made a lot more sense to me is changes in blood flow that occur during the operation. Fluctuations. And in that regard, I've always been interested that no one's been able to demonstrate that the use of a shunt decreases cerebral hyperperfusion syndrome. And your paper has a real opportunity to do so because you have a surgeon or surgeons that perform eversion endarterectomy, and I'm just assuming they don't shunt very often with eversion. It's a little bit more difficult to shunt with eversion. So what do you think is the explanation for why shunting doesn't seem to attenuate the syndrome? Do we really understand the syndrome? Because if we did, using a shunt ought to be preventative.
Yeah, so I think that using a shunt actually just kind of puts you back into that same physiologic state that you're in prior to any sort of ICA clamping. So for example, if you had a 90% stenosis and you put in a shunt, you have that transient moment where you've now clamped the internal carotid artery, but then you're reestablishing flow that's, for all intents and purposes, going at about the same amount of the pre-clamp physiology. And so I think that it goes to show that, not having a very statistically significant change in the patient's shunt or not shunting groups is actually helpful in terms of determining whether or not a patient is to have a headache. And I think that's been shown time and time again that there's not truly a real statistically significant difference there.
So your paper was your study was comprehensive, but you did not report the usual complications and stroke death rate. That wasn't the focus of the paper. But did intraoperative hypertension or postoperative hypertension, was that a risk factor for the development of hematoma and the requirement to take this patient back to surgery to re-explore the suture line?
So in fairness, that wasn't something that we actually looked at in this paper. So unfortunately, I can't really speak to exact numbers, but anecdotally speaking, going through the raw data, our complication rates in terms of having hematomas postoperatively was not very high, certainly, and wasn't something that kind of raised flags for me as I was going through it. Now, the normal reported postoperative metrics, for example, like stroke and death, I will point out that our stroke rate was 1.5%. And the vast majority of those 11 patients actually had very minor strokes that after a little bit of physical therapy actually regained most of their strength back. And so that only amounted to about 1.5%, which is in general pretty low. And then certainly, again, myocardial infarction, I think everybody's very familiar with the CREST data. And for us, it was actually only about 5 people. And they were actually diagnosed with all type 2 demand ischemia. So not true myocardial ischemia as one would think. And deaths certainly were not, again, something that we were looking at to go ahead and follow in the like the 10-year period that we were looking at, but certainly within that 1 month period from the actual surgery date, we don't really have deaths to really report. And so it was really, things that, for example, that one patient that we reported who had that MCA distribution hemorrhagic stroke after the carotid endarterectomy. Unfortunately, that patient actually passed away after the 1 month period. And so that's why, certainly our death rates and our, things of that are pretty outstanding.
Dr. Mills asks, how would you manage a post-carotid endarterectomy patient with mild headache and a blood pressure of 140/85?
So certainly my first mild headache is those real gray, ambiguous areas. And so I'd actually start off with some IV Tylenol, and then certainly would use Cardine for the first, overnight period, trying to drive that pressure down to something that's more normal tensive, something around like a systolic blood pressure of 100, making sure that we do go back and talk with the patient and elicit a little bit more history. Maybe the patient is a heavy caffeine drinker. I've had multiple times where patients go and say that, they haven't had their coffee or something like that. And often that would be, a reason why a patient might have some headaches. Now, I know that myself and my co-residents are very diligent in following up on our patients and making sure that that headache eventually resolves. In my experience, that mild headache typically resolves after a dosage of IV Tylenol and a little bit more strict blood pressure control.
Well, I congratulate you on a great study, very convincing, an odds ratio of 2 for, relatively poor intraoperative blood pressure control is remarkable. And I think this puts that particular question to bed, at least in my mind. I'm going to call on the world's expert in this syndrome, Dr. Rockman, just to make a few final comments and close out the section. Karen?
Well, can you hear me okay? I'm not sure about that, but thank you for the opportunity. This really is an interesting syndrome, and to anyone who does a lot of carotid surgery, I've had this happen to me, and it really is devastating. So I think anything we know about it, the better. The issue about blood pressure management, there's a lot of things that probably many of us do during carotid surgery that we just do because we were trained that way, right? Keep the blood pressure up during clamping, use shunts in patients with very high grade stenoses and recent strokes, that there's not a lot of data behind. And I think this helps to elucidate that. And I think looking at headaches as a surrogate of the syndrome is actually important, because the syndrome itself, hemorrhage doesn't happen enough that we can really study it well from a scientific point of view. I do think in patients with severe headaches, someone mentioned something about seizures. An EEG can show early signs of hyperperfusion syndrome, and I'm forgetting the term. I think they call these lateralizing epileptiform waveforms or some term like that. But in a patient with severe headache that doesn't have changes on the CAT scan, that's one good way to document something. And if you think the patient's really at risk for bleeding, you can also choose to stop their antiplatelet medication and other things.
Well, thank you, everybody. Such a great discussion, 2 really good papers bringing up things that we see and that we really want to know how to treat a little bit better and how to change the world, as I like to say. I thank you all for being here in February. Remember, we will have more every month. We meet usually the 2nd week of the month. It's advertised on social media. It's advertised on the JVS and SBS websites. And we look forward to seeing you all next month. Have a great night.
Thank you very much.
Thank you.
Thank you all to the presenters. Thanks.